Welcome back, everyone, to an episode of Fertility in Focus. Today we have with us an amazing guest. Her name is Dr. Jennifer Kulp-Makarov, and she is an REI. She's the founder of Fleura Fertility, practicing for over 16 years and trained at Johns Hopkins and Yale. She has now, at this point in her career, seen thousands of women couples and LGBTQIA+, helping them conceive even despite very challenging cases. She's really great with individualized IVF protocols, trying to get away from these more set protocols at some of the other centers. We're going to talk more about that. Excellent at IVF over 40, which very few are good at. So I'm
Yeah.
so excited to hear more about that. And for women with low AMH, issues with egg quality, and poor response to conventional IVF protocols. Welcome to the show, Dr. Makarov.
Thank you. Thank you, Christina. Thank you so much for having me today. And I'm really excited to talk about all these topics because I feel like they're not talked about enough. And it's really important to get this information out there.
Absolutely. Wonderful. Well, let's jump right in.
Okay.
So, you're leaving an established big center to start your own practice. What pushed you to make that leap at this stage in your career?
Yeah, so I spent more than a decade at a very high volume IVF center managing very complex IVF cases. So that medical part of really challenging IVF cases, women who didn't have, or couples who didn't have good experiences or success at other IVF centers would come to me. And I got very good at the medicine part of managing the cases. But it became increasingly clear to me over the years that the medical part and the protocols are a really important piece, but they're not the only piece. The other pieces of the patient experience are really important. And having it not feel like a factory for women as they're coming through. I think it's so hard to continue the treatment when you're feeling that way and not feeling really supported. And so I felt like it was so important for me to be able to um, help with that piece for the patients too. And so, in establishing my own practice, I really want to create more of a boutique space where we can look at these individualized protocols and also improve all aspects of the patient's experience, whether that's feeling supported, higher touch with their doctors and clinicians, more transparency on the billing side of things. So it's really a more supported experience overall, along with that clinical expertise. So really trying to move away from that factory model and having a better patient experience overall was important for me, and moving on from that type of center.
Yeah, I totally agree. I've always liked referring patients to you because I feel like you were always thoughtful in that respect and very patient with educating your patients and customizing the protocols and making sure as much as you could in a larger center that that some of the administrative experience was buttoned up, right? Because it's
Yes.
hard,
Yeah. Yeah.
sometimes the billing and the admin it can be sloppy. And
Yes.
I feel personally that the psychological safety of the patient is huge and can potentially affect their outcome. So if they're being stressed out by, something that's going on with the billing or not being able to get a hold of their doctor, not understanding what's
Mhm.
happening, maybe the protocol not being delivered appropriately by the nurse or whatever,
Yeah,
that
I
it
mean
can
that's
really.
gonna affect, yeah, I agree. That's gonna affect their stress and their, when you're dealing with not able to get pregnant or miscarriages, you're already at a high stress level for most women and couples, and anything we can do as providers not to add to that, or like these other pieces to have those stress free, is so important, I think. And really, not only for the experience, but for the success of the treatment. Because if you're getting stressed by other aspects of it, ultimately it may be you're not able to stick with the treatment because of that. That's the thing I hate seeing the most is when woman or a couple is not able to complete the family size that they want because of the stress of the IVF treatment or the experience of the fertility treatment. And that's like the saddest thing that I see. And that's something that I really seek to improve. Like everyone should be able to do treatment in a way that's comfortable for them and a lower stress, supported environment so that that is not a reason they're not growing their family to the size they want it to be. And I've heard those stories over the years. And that's also something that's really motivating me to make this change, as that's never something I want. And I don't think should ever be, whether it's the super high dose medications which are just not necessary, or these other pieces of the experience that are creating an environment where women aren't able to, and couples aren't able to complete their family size. Like we really need to move away from that.
Yeah, no, I totally agree with you because a lot of it is like the perseverance, right? Just
Yeah,
like to keep going. And I
it's
think
tough.
I
It's tough. The IVF warrior and all these ideas. It's true. It's tough.
oh yeah,
It gets
it's
to be
dog eat
tough. Yeah.
dog. Yeah.
But
And
but there are ways to make this easier. It doesn't have to be that. And that's really what I strongly believe and want to change. It doesn't have to be that hard. There's how IVF has grown up and fertility treatment has grown up in this country hasn't always made that experience easier. And I think there's an opportunity right now to change that experience of fertility treatment. It does not need to be that way. It does not need to be a factory. It does not need to be super, super high dose medications that make you feel awful. It's just there's no need for that. It's time for it to change. That's what I believe.
I love that that's your view and that you believe that it
Yeah.
can. I mean, I do see a lot of like I have a lot of people come that, I feel like they could have been better prepared for what IVF was going to be like,
Yes.
there could have been a bit more counseling at the onset about particularly depending on their profile, that this could be this might be one cycle, this could be a number of
Right.
cycles, and this is what to expect, and this is what you'll be going through kind of thing. Just sort of being very clear about expectations. Not that it won't work, but that you might need to be playing the long game. I'm sure there are a lot of considerations that could be voiced just to help women, couples, and LGBTQIA plus
Yes.
understand, what they're getting into and how to prepare themselves accordingly.
Yeah, I think so. I always was so interested in the science behind that, how the egg fertilizes and grows, because I'm still at this point in my career so amazed by how that works. But I think it's something that, it's not like we're taught in school when we're younger, oh, this is how fertility works and this is how egg and sperm work. So I think that's important. A lot of the education, even I had part of what I had done is hire some younger women who were interested in going to medical school, and I have them work with me for a year and helping me with the patients. And I asked them recently, what's something that surprised you about all this? Like now you're coming in with fresh eyes into the fertility field and you've really worked in it for a year. What surprises you? And they said, like, one thing they never knew is that when you collect a group of eggs, say you collect 10 eggs, that you don't end up with 10 embryos, and those embryos don't all grow into a pregnancy. Like there's nothing wrong. It's just this is how nature works with fertility, is that those 10 eggs, they're not all going to grow. They're not all going to fertilize, and then they don't all grow to an embryo. And those embryos that can look really good and get graded well by the embryologist, not all those have the potential to be viable. So it's just like setting the expectation for these things, or educating, because like who would know? No one would know coming in. You think, oh, I grew 10 eggs. That means like 10 embryo, 10 chances. And, 10 eggs is great, but it's just like knowing what that expectation is. Because I think if you don't know, it's another thing that adds to the stress, right? And you're like, oh, this went so terrible. Whereas I, as a fertility doctor, I'm thinking, okay, we got like a few potential embryos at the end. This is great. This is exactly what I wanted. So,
Yeah, because they're envisioning it almost as like a failure, like the the
yeah,
the stages of attrition. Like, oh, I thought maybe more would grow, or I thought more would be retrieved. I thought
right,
more would
right.
fertilize. Like, this is potentially a failure on my part.
Yes. Or
And
feeling
that
it's bad, something wrong with them or their egg quality, whereas actually, like, no, this is just a biology. Like, it's such a complex process when the egg and the sperm have to come together and then grow into an embryo. And it's just naturally prone to errors. So, like, you could do everything right. And this is just how the biology and the process works. So.
That's a very uplifting viewpoint.
Yeah.
Um, so I know you had many years experience in mini IVF protocols and have, gone and really tried to get away from set protocols and really focus on customizing. But since, you have so much background in mini IVF, maybe we should get in a little bit to talking about the advantages and disadvantages of that and how you have diverged into a more customized approach.
Yeah, so I guess just speaking briefly about conventional IVF, because when most women or couples go into a fertility clinic in the United States, they're going to be given what's called a conventional IVF protocol. So what this is high dose, mainly injections and multiple injections a day. When IVF first started, it was that we want to shut down all the hormones your body's making, basically, like shut them all down, and then we'll just replace them all with these injections or hormone injections and pretty high dose hormone injections. Because this idea that every month you have a group of eggs that starts to grow, naturally your body will make these hormones to allow one egg to mature and ovulate. And with the fertility medications, you can get the whole group to grow. So that's the way IVF first started. And honestly, it's a way it's practiced in a lot of places across the country is this conventional, like, okay, it's easier or it's been done for so long. We just completely shut off the body's hormones and replace this with high dose injections. So then the idea with mini IVF is that, okay, but the injections, what you're injecting in your body during IVF and all these protocols are hormones FSH, LH, or hormones that act like those in the body. But you know what? Your body makes these hormones naturally. So why are we shutting them off? We should be using those natural hormones your body's making. And mini IVF came about, but naturally your body, right, it's only going to produce enough for one egg. And ideally for some of this we're talking about with IVF, and if possible, it's not always possible, but if possible, if you can get a group of eggs, that's is the goal for some IVF cycles. So the idea of mini IVF is you can give pills. Some of these pills are like Clomid or letrozole, and these will make your brain make more of your natural hormones. So it's going to make more FSH and LH naturally or in response to the pills, and that can get a group of eggs to grow. And then you really can move away from all these high dose injections, which are expensive. No one wants to do lots of injections, and there's
You
more
feel
side
much worse.
effects.
Yeah. Hmm.
There's more side effects when you're taking massive doses of hormones. Plus, it's just like, I really feel like it's so important to move away from that because no matter what, I mean, this works really well for women with low AMH, but for any woman, you don't need to take massive doses of hormones to do IVF. And actually, sometimes it's just even, especially for women over 40 or low AMH, it's like counterproductive. It's too much for the eggs. But at any age,
Yeah, no,
I
I've
sort
seen
of
it.
like, I don't want to limit it to that group.
Yeah. No, I think you're right. Like I've
Yeah.
definitely see the mini IVF be an option for women with PCOS, so they don't hyperstimulate, right?
Yes.
They don't get like
Yes.
potentially unwell from it. And then I definitely do see it for the women with low AMH over 40, because what I see with them is if you use too many medications, oftentimes the ovaries just like arrest. It's like
Yeah.
arrested development,
Yeah. Yeah.
they
Yeah.
go on strike or the quality is
Yeah.
really
Yeah.
bad
Yeah.
because they
Yeah.
were basically toxified by
Yeah.
all the medications. The patients can be traumatized just by how bad they feel or how bad the result is. And I see just as good, if not better, results with a more delicate approach to the
Yeah, it's going to be better, especially on women over age 40, because what I like to talk about is this Goldilocks approach. Because what happens when you're over 40 or with low AMH is your body's naturally pumping out a lot of FSH. And so if you inject massive amounts more of FSH, you can see how it overwhelms the receptors on the eggs, and they just kind of freeze and don't grow. So what eggs need, and this makes sense, right? What eggs need is this like Goldilocks level. They need this just right level of FSH. So something that's done with mini IVF and the more personalized IVF that I like to use now, because mini IVF sometimes can get a little stuck in like no injections at all. And listen, for some women, they do need a little bit of injections to get the eggs to grow. Almost never the high dose that's so common in this country, but there's a good chunk of women who are going to do best with a small dose injection along with pills. So that's where I really like to personalize the IVF. I've not got too stuck in mini, which is more like pill based. But that idea that like when you're over 40, your brain is making lots of FSH. So if you inject massive more amounts of FSH, it's not going to work. The eggs are just like, oh, it's too much for them. So what you have to do is really check that natural FSH FSH level through the cycle. So that's something that a lot of clinics don't do. They won't they'll check FSH once and then never check it again through the cycle, and really that's not helping the eggs. The eggs really like a medium level of FSH, and so if you check it through the cycle and adjust your medication to just that right level of FSH, you're really going to get the best results. And it's so much more patient friendly, woman friendly, because you're not taking those heavy hormones injections. So
This
yeah,
is so cool.
yeah.
So what would be like a range of FSH that's a healthy range if you're checking it through the cycle?
Yeah, a lot of, naturally what happens, and this shifts as you get over 40 or with lower AMH, that the FSH will go up on the beginning of your cycle, but naturally the FSH should be pretty low. So something we do is start before you're even getting your period, because we want to bring you into your cycle with a lower FSH and then let it gradually rise. So, and what a good level of FSH for egg growth tends to be 15 up to 30, and that range is a really good range for the eggs to grow. But
Amazing. This is great. And
yeah, every woman's gonna have, like, listen, every month you have a new group of eggs there, and that number is gonna vary person to person a lot. That's called your antral follicle count, what we check on ultrasound when you come in to see your group of eggs. But month to month, that group is gonna vary. Person to person, that varies a lot. So really, you need to also personalize the medication, the FSH levels for that group of eggs. Sometimes depending on factors like age, even BMI, you're going to need different doses to get to that good level of FSH for your eggs.
wow, this is magical. I really love this. So,
Yeah.
okay, because it's just, it really is like highly customized. And not only are you
Yeah.
checking, you're considering multiple factors, some of which you can continue to check throughout the cycle and adjust accordingly rather than just
Yeah.
being like, "Here's the protocol, that's what it is." So
Yeah,
I
yeah.
I
That's, I
love
think,
this.
some, yeah, that's a part of the issue that comes up with these protocols that are set. Like, you're going to do this conventional, you're going to do this many. It's like, okay, but that's not how the body works. It doesn't want like a set protocol
Exactly.
and just go, It,
Well,
you
yeah,
need,
that's what
yeah,
I thought sort of like that in my, system because Eastern medicine is all customized, right? So it's really
yeah,
scale it because it's all, customized to the individual. And my perception of, Western medical practice is a lot of it is bucketed protocols, right? And so
yeah,
but I do think like, being specialized in fertility care that I have seen patients get better results with an approach like yours, which is, really thinking about the details and looking at this more critically. And what I think has happened with a lot of medical care is the factory model makes it so that doctors don't have time
right,
to think or like critically or really give the time to that patient. And they do okay with a certain
right.
subset of people,
I
right?
think so.
Um,
Yeah, I think that's right. Yeah.
but like I think most people would benefit from your
Yeah, there's a
approach.
better way. You can feel better during IVF if you don't have to take such heavy injections, because that's true, for a subset of women, super high dose injections, they will make the eggs grow. But there's a better way. You don't need to do that to get the eggs to grow.
Yeah, you could still get just as good of results, if not better. I
Yes.
guess that's just like it's, in America, I guess they're just leading with that, right? That's it. Because I know it's not
Yeah,
necessarily like that in other countries. Yeah.
I think that's part of it. I mean, there's good and bad things that the pharmaceutical industry is, um, you know, can develop new medications, but they're also like very aggressive in the United States, which is different than other countries. So certainly in other countries, like you're saying, it's also not as common to use such heavy high dose hormones. It's really the United States, I think, stands out around the world for using these type of IVF protocols.
Well, it's a culture of like, you know, more is better,
Yes, yes,
no pain,
definitely.
no gain, and
Right,
not to mention
exactly.
like highly capitalist, right? Like
Yes,
it,
yes, which is good and bad.
definitely. Like when I hear about protocols in, say, France or some of the European countries, it's definitely more delicate, right? Now the
Yeah,
advantage of doing your IVF in the United States is that you do have more options. Like you're not able to do
yeah,
the PGT testing there and there's like,
right. There can be
you could do
long wait times in a lot of those countries. Yeah, absolutely.
yeah. So I definitely think that, the right balance is finding somebody like
Yes.
you in this
Yes.
country to do it this way. So what are some other nuggets of wisdom or, nuances to your approach that help women with more challenging cases?
Yeah, I think it's really important to look at why the IVF didn't work. So if someone is coming where they didn't have an IVF work, you have to look. So eggs and egg quality is really important. So it's something I definitely focus on. But I think there's other things you can look at or that are important to look at too, besides the egg quality. So an egg is combining with a sperm. So I think sometimes in these conversations, because egg quality, listen, it's really important, but it's not the only thing. So I think looking at the whole picture is really important too. So some key things I see there are you need to look at the sperm quality. So that's something I've been talking about more too, because that really contributes. That plays a role into making a quality embryo, and it's something where when we get too focused on the egg, we're missing that piece of the picture. So that's something that's really important to look at. And listen, it's something that can really sometimes we can really make a big difference there because the biology is so different for men. They're making millions of sperm every day, and it's something that like sometimes it is easier to shift than egg quality. So that's a piece that I always look at. Um,
I love that because really what I hear a lot of doctors say is just like, "Oh, sperm's not ideal, but we have ICSI, so don't worry about it. Don't
yeah,
don't you think it,
yeah,
I'm like, I don't really because like you can't see everything when
no,
you
you
take
can't
that
see
sperm and
everything.
inject it. Yeah.
Yeah. And there's like, something that I've been talking about too is like, when we're looking at like, sometimes when we get embryos and that look really good and implant them, and then something like a miscarriage were to happen, we've looked at like what does sperm contribute to this at all? And it turns out there's more information that sperm contributes to that because they're playing a role in that. And there's, you can look at the semen analysis and sometimes you'll see things there like the lower motility or morphology, but you can also look at sperm like DNA and look for damage to the sperm DNA. And when they've looked at that, they found that men with higher DNA fragmentation index, that their partners are more likely to have miscarriages. So, it plays a role.
Thank you.
Yeah.
Thank you for involving the other half of the equation. When I see
Yes.
women, when their first case, I'm always like, I know your husband or your partner or sperm donor or whatever is
Yes. Yeah.
um so, how is their sperm? Like
Right.
has there been any attention on this? And
Right. 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 It's
like,
important.
oh, they did like a basic sperm analysis and maybe the morphology was off, maybe the motility was not so great, but the doctor said it was fine. And I'm like,
Yeah.
okay. And so
Yeah.
then I'm going
Yeah.
through some counseling about what men can do, right?
Yeah. It's
I
so
definitely,
important to optimize that. Yeah.
yeah, and I don't have the tools to be able to do this extra additional testing. So I'm so glad that you do that and that you do
Yeah.
focus on it. Because I mean, when people are like, well, why don't they focus on the men ever? And I'm like, well, I hate to be cynical, but like they don't really make money.
You're
It doesn't make money to focus on the men. And that's not all of what it's about. It's also about the fact that, IVF centers are focused on stimulating ovaries, right?
Yeah,
And
so a lot of REI, all REI doctors really come from a background of women's health, and
yes,
they all do
exactly.
like training in OBGYN, and that's all women and women's health. So that's really their background too. So I think that's part of it. I mean, there are, urology is really more what focuses on the men, and you'll see a few urologists that are focused on male fertility, and that's their background. But when you're going to a fertility clinic, those doctors have much their background is women's health, so I think that's part of it too. But I mean, that's changing because you can't just look at the eggs. I think you really have to look at that. That's definitely a key piece.
Well, that's actually one of my questions. Like, 5 years from now or 10 years from now, what do you think will have changed most dramatically in fertility treatment?
Yeah, I think that's something that will change. I think I think we're going to have to move away from these protocols, from these set protocols, and from these high dose medication protocols. So I definitely think that will change. Oh, I hope anyway. I hope that will change. It really needs to change. So that's something. I think there's going to be advances in embryo, how we can screen for embryos. Right now, the test that we do, the PGTA, it really doesn't screen for disease. It's really looking at like viability in the embryo, and it's not a perfect test. So I think there's going to be advances in how we can screen embryos for viability and for disease. I think that will be coming up as well, and that will play a role into like the IVF lab. It's always getting better and better. I feel like in every 5 to 10 years, there's advances that happen in the embryology lab that can improve these outcomes in IVF. So those are some simple things. that I see improving.
That's so interesting.
Yeah.
What would you say, if we're thinking about, a demographic that you seem to be very, very experienced with,
Yeah.
these women who are having low AMH, low ovarian reserve, or advanced maternal age that maybe are likely not to get a ton of eggs in a cycle. Um,
Hmm.
what would you say to a patient like that, at the onset to just, sort of hopefully make them not feel bad and make them feel like that it's okay. The outcome's going to be okay, even if you're not getting, a ton of eggs, not to
Yeah.
discourage them from the approach entirely. Yeah.
Yeah, no, I think that's something important because the bottom line, in the end, we just need one egg that can grow into a pregnancy. So it's important to know that. But I think if you compare it to what you're seeing on social media or what your friend did, where they maybe did one IVF cycle and they were done, well, that when you have lower egg reserve or when you're over 40, I always say it doesn't mean we can't get there, that you can't get pregnant, but it can take more work. And so it's important to know that sometimes it can take, we're not getting as many eggs in one egg retrieval, and that's okay. And I don't cancel egg retrievals because we're not getting a lot of eggs. It's a person by person decision, but I have patients who come to me and say, well, I didn't grow 4 eggs, so it's automatically canceled by the clinic. And it's like, okay, but one of those eggs could have been the one. So we have to keep in mind, you may not get a lot of eggs in one egg retrieval, but it doesn't mean you can't get there. If we do 3 egg retrievals, then maybe you're going to get there. So that's sometimes what it takes. It can take 2 or 3 egg retrievals because we need more eggs to work with. Sometimes we get it the first time, but sometimes it takes more work to get there. Like maybe the journey is going to be longer for you. It doesn't mean you can't do it, but the journey is going to be different than your friends, and it may be longer. It may take more work in there. So I think that's important.
Yeah, you definitely can't compare like a 30-year-old with high ovarian reserve to, let's say, a 39, 40, 41 year
Yeah.
old with like a lower ovarian reserve.
Yeah, they can both
It's not
end
the
up
same experience.
like they'll both end up pregnant through fertility treatments. They both will, but their journeys are going to be very different. Their experience is going to be very different as they're going through. And I
Yeah,
think that's hard. I think that comparison can make you feel so bad too. It adds to that stress. So, and a lot of times what you see on social media with your friends, you're going to hear those stories where I did one egg retrieval that was fine. I had a baby or 2 babies from that. That's not everyone's experience. That's okay. You can still get pregnant through IVF, but your journey is going to be different.
yeah, you might be playing a bit more of a long game, like a marathon,
Yeah.
not a sprint so
Right.
much,
Yeah. Yeah.
right?
Right. Right. Yeah.
Um, Now we were talking the other night about labs and how, some of the centers are sort of like still riding on a reputation of this amazing lab that they had, eons ago.
Yes.
And you were voicing that lots of the labs are really good now.
Yeah.
And so how should patients like discern, where they're going in terms of the lab? What kind of questions should they ask beyond just, recognition from the name from, a big name from 10 years ago kind of thing?
Yeah, I think it was hard about, like 10, 15 years ago, when there weren't as many IVF centers. The lab was something that was new. Maybe it was harder to learn. A lot of those protocols in the lab have become standardized, and we don't see as large differences in the IVF labs as we used to. So I think it used to be maybe there were like one in the state that could really do IVF. Now it's like most labs can do IVF. That being so, there's not this huge difference in quality of the lab. So some of those older labs, I would say I've seen a lot of maybe private centers that are really outperforming those large academic centers now. They have like to really focus on quality to survive in this environment. And honestly, I see some of those smaller labs doing better than the big academic centers at this point. But it used to be the thought was only the big academic centers had the good labs and that's where you had to go. And it's really just not true anymore. Again, I see some of these smaller labs doing better than there's huge academic centers. But some things you want to look at, I mean, there used to be this focus on the field only on like pregnancy rates and one egg retrieval, which again was like, it doesn't make sense. That's not how it works for a lot of women. And what would happen is those centers, and we still see this a little bit, is those centers will say like, oh, well, it's going to take more work for your case, or maybe we won't be as successful with your case. So you're not like a candidate to do IVF with us here because we don't want to hurt those success rates per cycle. Everyone was so focused on that. But there are other things you can look at in the lab. So you want to look at the volume of experience. So how long have they been operating, and things that you can look at and ask about in the lab that I look at as a physician is how are the eggs fertilizing? Because even when you're doing ICSI, the eggs 100% are not fertilizing. And there is some skill in doing the ICSI actually. So something you can ask about is what is the egg fertilization rate in the lab? What is the blastocyst rate development in the lab? So these are some factors that you could ask about and look at in the lab. I think, coming into IVF and focusing on the medications and all those high dose injections that most women have to take. But we forget to ask about these pieces sometimes that are important too. So those are some simple questions you could ask to understand how the lab is working, how well it's
That's
working.
incredibly useful. Thank you
Yeah,
so much.
yeah.
I had a patient question yesterday about some claims around rapamycin. Uh, I mentioned that I was gonna maybe bring this up. What is this drug that what can like have you used it? Does it show promise in for the short term in, helping with egg and embryo quality and cycle outcomes?
Yeah, so rapamycin is a drug that was used for transplant patients. And then it was picked up by sort of clinicians in the longevity space. And there was a small study that came out that looked at using rapamycin in women to improve egg quality and prevent depletion of the egg supply. So it really shows a lot of promise there. I think, it's much more common. I had a patient where come to me the other day where she was interested in it, but said, I haven't yet prescribed it because it's so brand new in the fertility space, and it's a transplant medication. So the first thing is you don't want to do harm by getting this like heavy medication. But listen, it does show a lot of promise. So I had a patient come to me and said, well, I just went online, a televisit with a longevity doctor, and they gave it to me. So I'm taking it for fertility. I got it for fertility. I got it from a longevity doctor. I said, okay, well, let's see how it does. I am very interested in it. It's showing a lot of promise. I'm excited about it, but it's really brand new. So we just want to make sure what are the side effects that would come with it from it if you're using it for fertility, just to make sure we're safe. But it's really exciting, I would say. It's really it shows a lot of promise there. It's such a hard thing to fix, this egg quality issue, because the women as you're losing your egg quality with age. We haven't had any way to stop or slow that meaningfully. So this is a medication that maybe can do some of that. So it's really exciting, but it's like I've barely seen it be used in infertility, just starting. So yeah,
Yeah, and it's like, and I totally am with you on the like do no harm, right? Because a lot
yeah,
of the things I recommend, oftentimes they do help with cycle outcomes, and I'm generally confident that they will do no harm, right? When we
right,
get
right.
into like newer drugs or drugs that haven't been used in this part of the field, it's who are going to be the people to test this out, right? And
Yes, yeah,
and
yeah.
the brave, amazing patients that are willing to maybe they've had really not good results so far and are willing to at that point try something new, even though it might be considered a bit more experimental or avant-garde, right?
Yeah, yeah.
I
So
love
I
how
think that
open you are and that you're excited about, the
yeah, I'm excited.
possibility.
I really want to follow the development, and once like I'm confident that it's not gonna hurt, what's like some side effects, then absolutely, I think there are some newer things for egg quality that have more evidence right now. Like something I've used a lot is ovarian PRP, which I have seen a really meaningful difference for women with the egg quality issue. I have a lot of experience with that and have seen that really shift. Where women, I've had women come to me where we cannot get a blastocyst or embryo that has some viability, and after PRP, it makes that shift that's so hard to make where we're getting embryos with viability. So that is something that I use at this point to shift egg quality.
That's amazing. How much do you have to do the PRP? Like I think it's done in different sessions, right?
Well, so there's PRP. So PRP can actually help you can infuse it into the uterus and it can help for implantation. So that's one way to use it, which is probably not used enough in my opinion. So that's something to consider. But for the ovary, we have to put it, that's best used to put it directly into the ovary. There are a few centers where I've seen where they just like say they like kind of drop it over the ovary, but that I think it's better to put it right into the ovary where the eggs are. So it does require a procedure to do that, but It's similar to an egg retrieval, but less, I would say, because you're not like the ovary's not getting enlarged with multiple eggs, but you are going vaginally into the ovary in a few spots to put the PRP. And the PRP is a blood draw from your own blood that's spun down with lots of natural hormones and growth factors. And then that's put into the ovary, into each ovary in a few spots. Now, the PRP will take a few weeks to work. So it takes 2 to 4 weeks to really get that optimal effect. Once you're getting that optimal effect, I've seen that last, depending on the patient, for 3 months, give or take a month there. So some women who are doing it for fertility treatment will do it and then try to optimize their fertility treatment for those few months where we really see it working. And then oftentimes that's enough, honestly. But there is some evidence that if you repeat it 2 or 3 times, you can kind of get booster effects with the PRP. So after 3 or 4 months, do a second dose if you haven't gotten the results you needed in the first 3 months. So there is that option. Sometimes we don't need that though, because it's working in that first few months where it's really making that shift in quality.
Goodness, I love all of what you've been doing and
Yeah.
just like really, such a focus on getting better results and knowing that it's possible and knowing that there's a way if you just keep on the path and
Yes.
I think this is so cool. And
And I
so,
think sometimes a different approach is important too, because I think when you go to one clinic, and rightly so, you're kind of attached to that clinic, but you're doing IVF cycles and they're not working. It's time to it's important to change something. You need a change. You need a different approach with protocol, a different lab, a different technique like PRP. Like if it's not working, you don't want to just keep doing the same thing. So I think
yeah,
that's
you also have
important
to be
too.
brave and creative enough as a doctor, right? Because so some
Yes,
of
that's
the
true.
larger centers, the larger academic centers, not all, but most of them have like a bureaucracy. Like this is like the head guy says these are the protocols we do, and that's what it is, right? Like don't color outside the lines. It's not scientific
Yeah.
enough. It's not, there's not enough research to support it. And so, when you're getting into these areas with a little bit less research, as of yet, but it's safe, and then you start trying
Yeah.
yourself and you've seen it, have some
Yeah. Yeah.
positive effect. You just have to keep on the path because we're going to see in 5, 10 years that, this has been something that maybe could have been practiced by others. So you're really at the forefront of improving IVF and the
Yeah.
outcomes for these patients that traditionally were having much rougher times. So
Yeah.
before
I
we
think
before we sign
I,
off,
I
go
just
ahead.
want to add one point about that, which I think
Yeah.
is important because it's something I've seen coming up a lot in IVF, and maybe women and patients aren't that aware of it. I do think it's important. I'm in a unique position where I have that lots and lots of experience doing thousands of IVF cycles, and I have been able to personalize it and choose alternative methods. But I think all doctors tend to want to do the best for their patients. But what we see in the fertility world right now, and especially like in New York City and other places, is that most of these fertility clinics are owned by private equity. So they're owned by these big businesses.
Yeah.
And, ultimately in the end, they want a standardized protocol so they can maximize profits. It's
Scale.
true. I think it needs to be said, so women are aware of this. Those doctors have no flexibility. I mean, I had spoken to one recently because it was a big fertility group and looking maybe to work with them, but they were like, well, you can't really treat many women over 40 because we only have one protocol that works. We need to standardize it across our whole network, and it doesn't work for us if you're treating women with low AMH or all that. That's just like you can't do that. And that's like, okay, this is not going
Well,
to
then
work
I'm
for my
definitely
beliefs, but
working with you. No, we had talked about yeah, because
yeah.
never thought this would happen. Acupuncture in New York has gone private equity, where
Yeah.
like it's just like you can hire sort of anybody like a McDonald's. You put them into the system. You teach them the system, the protocol, and
Yeah.
it takes away the magic of the
Yeah.
medicine. What's possible for people again, like anybody who's like a little bit outside the box, because that standard conventional protocol only works well for a certain subset.
Yeah.
Um, so
And
on
they're looking
that
to
note,
maximize their profits in the end, so they don't
of
want to like
course,
personalize or yeah.
no, not venture capital. It's definitely
No.
it's definitely
That's
it's like
not the goal.
it's like this is a profit system. Like it's not a help the little guy system.
Yeah.
Um, and so, for you, what other nuggets of wisdom would you want to leave our listeners with as they're embarking on their journey?
I would just say I think it's really important to know that fertility treatment isn't one size fit all, and it's really important that you're comfortable with the journey, and so you're partnering with whether it's a doctor or a clinic who can give you IVF or fertility treatment in a way that works for you. Because at this point and where we are with fertility treatment, it can really be personalized, and it should be something that you're comfortable with because you don't want to stop your fertility journey just because you feel it's too much or there's not options. There are options for different ways to do fertility treatment that don't, again, involve super high injections. And I think that's important to find that right place where you're comfortable with the treatment plan, and just know that there are other ways that work as well, if not better, that do not involve heavy injections. It's just not how women need to be doing IVF anymore.
That is so well said. Thank you so much for bringing all your wisdom. Dr. Makarov, where can our listeners find you?
Yeah, so I am on social media. Dr. Jen Fertility Friend is what on Instagram or TikTok, YouTube. So I have all those channels where I do a lot of education. I'm posting multiple videos a week, so you can easily find me there. And FleuraFertility.com as well. I offer virtual consults across the country as well.
Oh my gosh, amazing. Thank you again for being here. Thank you for all your wisdom.
Thank
This was
you.
an amazing conversation. I'll be definitely asking you to come back again.
Oh, good. I would love to.